Well, hello everybody. My name is Dr. Jeffrey Buchanan. I'm a professor in the psychology department at MSU Mankato, and I'm also the principal investigator of the research study that you're going to hear about today. Now, I'm guessing if you're watching this, there's a good chance that you were a participant in this study. And I met with many of you individually, and I promised you probably on more than one occasion that eventually we were all going to get together and we were going to tell you about the results of the study. And this is not exactly how I planned on doing it, but this is the best we can do, of course, under these circumstances. But this will be our chance to share with you the study, what we did, and what we found. This is a study that I have really been planning and thinking about for years now. And in order to carry out a study of this magnitude, you need a lot of really good partners and collaborators. So before we get into the results of the study, I do want to say a few words of thank you to a number of people. First of all, to get a study like this off the ground, you typically need some funding. And so I want to thank MSU Mankato for providing me with a faculty research grant to help fund this study. I'd also like to thank Mankato Clinic, who provided Vine Faith in Action with some funding to get this study off the ground. And then speaking of Vine, of course, I need to profusely thank the people at Vine for helping us with recruitment, for providing these wonderful facilities, and to the individuals who helped to run this class. And you know them. You know Adam, Katie, and Carol, I think, did most of the class work. And they did a wonderful job learning this program and then delivering this program so well. So I have a lot of thanks to Vine, of course, for helping us get this study moving. And we hope to continue these programs in the future with the collaboration of Vine. So they've just been wonderful throughout this process. I also need to thank the New England Cognitive Center. They're the individuals who developed the Mind Sharpener program that you may have participated in. They've been developing these programs for 10 or 15 years now, and I've been collaborating with them for about a decade. And I just need to thank them for allowing me to have access to the programs and to do independent research. So they've really been wonderful collaborators as well. Probably the people that I need to thank the most are you, the participants in this study. We can't do a study like this unless we have individuals who are willing to participate. And we put you through quite a lot. You devoted a lot of your time and a lot of your energy to participating and helping us out with this research. And so I just really thank you so sincerely for spending so much time with us and putting so much effort into this project. And I think it's turned out to be a really good project that I know I'm very proud of, and we're excited to share the results with you. The last individuals that I need to thank are my wonderful research team. You interacted with a number of them in doing some of the tests. I have a lot of graduate students and undergraduate students that helped get this project up and off the ground. But most of all, I need to thank Jackie Gehling, who is a graduate student who works with me, and she was really the primary point person for this study. She ran this study. All of you have interacted with Jackie in some way, shape, or form, and she did a wonderful job organizing and carrying out a very large project. And so what I'm going to do now is I'm going to turn things over to Jackie because she knows this study better than anybody has. You should also know that this was Jackie's master's thesis. So she has recently graduated with her master's degree in clinical psychology, and this thesis was a critical part of her graduating. So you've contributed to somebody's education, you've contributed to the scientific endeavor related to cognitive training, and you've contributed to our research in general. And so again, I want to thank you. And what I'm going to do now is turn things over to Jackie, and she's going to tell you about the study and what we found. And then lastly, what I'll tell you is that you will see that my contact information is on the slide here. And so you should feel free to email me or call me if you have any questions about anything you hear today or any unanswered questions that you have. So again, thank you to all of you, and I hope that you enjoy the presentation, and I hope you're informed by the results of it.
Hi everyone, it's Jackie Gehling here, and I'm going to tell you about the results of the study that we worked on here. So the name of the study is The Effects of a Cognitive Training Program for Healthy Older Adults, and it was a program evaluation study. So like Jeff mentioned, this was my master's thesis, and we'll get started today by just talking about the method of the study first. So I'll go through who the participants were in the final analysis, the materials that were used, and the procedure in which we conducted the study under. Then I'll talk about the results of the current study and discuss the results with you all. And then lastly, I'll wrap up with some conclusions about what we found. So the purpose of the current study, to get started here, is to determine the effects of a cognitive training program on cognitive and emotional functioning for healthy, community-dwelling older adults who report subjective changes but do not have documented cognitive impairment. So the cognitive training program evaluated in the current study was developed by the New England Cognitive Center, designed to provide older adults with mental workouts that maintain or improve their cognitive functioning. So there are 5 different programs, with each being adjusted for different severities of cognitive decline. Sharpener, which is the program that we evaluated, works with individuals that have no documented cognitive impairment and are just reporting subjective cognitive changes. The Sharpener program involves individuals participating in 2 to 3 one-hour classes for 8 to 12 weeks. So it's a total of 24 sessions that are in the program. And many cognitive training programs in previous studies were only computer-based. So individuals were working at a computer only and didn't have much social interaction. In this study that we did, this cognitive training program is socially based and is delivered to individuals with a live trainer. Classes include a series of paper and pencil activities that gradually increase in difficulty over time. So the program focuses on 6 cognitive domains, which are attention and concentration, visual spatial skills, memory, language, processing speed, and problem solving. So it's a comprehensive program that focuses on all of these 6 domains. So now to talk about the participants in the study and the setting. Of course, it was at Vine here in Mankato, and individuals living in the greater Mankato area were recruited with the assistance of Vine. So there were 4 separate Sharpener classes that were held at Vine. There were 31 participants who initially consented to the study and completed pre-testing, and there were 26 who completed the class and then completed post-testing immediately following the class as well. To be included in the final analysis of the study, participants needed to complete a pre-test, a post-test, and a follow-up test, which was 3 months following the completion of the course. So I'll explain more about the testing and what was involved with the testing next. But just know the final analysis included 19 Caucasian participants whose education ranged from high school to PhD, and there were 6 males and 13 females. So participants were required to meet the following criteria to be included in the study. They needed to have subjective reports of cognitive change. They needed to have an absence of cognitive impairment assessed by the Mini Mental Status Examination, otherwise known as 3MS. And so a score above 78 indicated that they were cognitively intact and able to participate in this study. They needed to have an absence of a diagnosis or condition that causes progressive dementia, which was assessed via self-report. And then they needed to have adequate vision and hearing to be able to participate in the cognitive training class. So now to get into the materials that were used. Materials that were used included a variety of tests that assessed the 6 cognitive domains that were targeted in the class, and then a few questionnaires. So of the neurocognitive assessments, the repeatable battery for the assessment of neuropsychological status, otherwise known as RBANS, was used, and it is a multi-component test that assessed those 6 cognitive domains that were targeted in the class. Then 3 separate tests apart from the RBANS were used as well, because they assessed the cognitive domains in ways that weren't assessed as thoroughly on the RBANS. So these included visual puzzles from the Wechsler Adult Intelligence Scale, and trail making Test Part A and Trail Making Test Part B. Then of the self-report measures, the frequency of forgetting scale was used, and this has 10 items that ask participants to rate their memory and how their memory might present some problems. So overall, it's just an assessment of participants' judgment of their own memory. Then the patient health questionnaire was used, and this includes 9 items that ask about recent depressive symptoms and how frequently they are occurring. And this is looking at just the last couple weeks. Then the cognitive failures questionnaire was used, and this consists of 25 items that ask how frequently minor cognitive errors occur, such as just minor problems in everyday life, like do you forget the name of an acquaintance, do you bump into people, things like that. So now to talk about the procedure. All tests and questionnaires were completed 3 times with participants. So each participant completed a pretest in the week prior to starting the class to establish a baseline score of the 6 cognitive domains that were assessed. After pretesting, then the participants began the Mind Sharpener program, where they all attended 2 one-hour sessions a week for 12 weeks, and that's how we completed the 24 total sessions of the program. Then in the week immediately following the class, participants completed a post-test, which included the same questionnaires with the exception of a different form of the R bands at post-test compared to pre-test. So for example, if a participant was given Form A at pre-test, they were given Form B at post-test to prevent what we call testing effects or practice effects, like getting better with a test just because you're practicing it. Then lastly, at 3 months after post-test, participants completed a follow-up test with the same tests and questionnaires and an alternate form of the R bands from post-test, which was the same form as used at pre-test. So if it was A at pre-test, it was B at post-test, and then it was A at follow-up test. Some participants started with Form B first and then ended with Form B. All right, now I'm going to discuss the tests being used for the pre, post, and follow-up testing and what cognitive domains they fit into. So for the attention and concentration domain, we had the digit span subtest and the coding subtest on the R bands. So for the digit span subtest, the examiner set a series of digits and asked the participant to repeat the digits in the exact order that they heard them. So the number of digits increased by 1 each round, so it did get harder going through it. And then for the coding subtest, the participant was asked to quickly write down numbers that were associated with specific simple shapes. And they were given 90 seconds to make it as far down the page as they could. For the visual spatial domain, we have the figure copy subtest and the line orientation subtest from the R bands. For the figure copy subtest, the participant was asked to copy a complex geometric design from a model. Then for the line orientation subtest, the participant was shown a series of line orientation cards, like what's shown on the bottom left of your screen. And for each one, they were asked to make a decision about which numbers corresponded with the angles of the line shown. Then another test that assessed visual spatial skills was visual puzzles from the Wechsler Adult Intelligence Scale. With this test, participants were asked to choose 3 shapes from the bottom that they could use to make the top shape. There were a total of 30 items that got more difficult as one progressed, and then in later shapes, figures had to be mentally rotated, so meaning that one of the shapes would be on its side, and so the participant would have to mentally rotate that piece to make it fit in the top shape. Now, to look at the memory domain, we had quite a few subtests from the R bands, and we assessed both immediate and delayed memory. The first one was the story memory subtest, and during the subtest, the examiner read a 2-sentence story and then asked the participant to repeat the story back right after hearing the story. Then, looking at delayed memory, After a delay of about 20 minutes, the participant was asked to recall the story. Then, for the list learning subtest, the examiner read a list of 10 unrelated words, and the participant was asked to recall the words from the list and repeat back what they could remember. So this list was presented a total of 4 times, and then again, after a delay of about 20 minutes, the participant was asked to recall the words that they could remember from the original list learning task, and then immediately following this recall, they then completed the list recognition test. And during this, the participant was asked if certain words were said or not. So they would just say yes if they thought the word was on the list and no if they thought the word was not. Then the last test that we used to assess delayed memory was the figure recall subtest. So after a delay of about 20 minutes, the participant was asked to recall that geometric design that they copied down in the figure copy subtest. So during delay intervals, other subtests of the R-bands were administered. The delayed memory test measured forgetting over time. So now to look at the language domain, we had the picture naming subtest and the semantic fluency subtest from the R-bands. So for the picture naming subtest, the participant was shown 10 drawings of common objects and asked to name each one, kind of like the seahorse on the top there. Then for the semantic fluency subtest, the participant was asked to say as many words associated with a specific category of objects as they could in only 60 seconds. So for example, they may have named as many fruits and vegetables as they could in 60 seconds, or named as many musical instruments as they could. Then the trail making test covered both the processing speed and the problem solving domains. So in trail making test part A, participants were given a sheet of paper with numbers randomly scattered on it, and they were told to connect the dots with numbers in order as quickly as they could. So they'd go from 1 to 2, 2 to 3, 3 to 4, and so on until they reached the number 25. So essentially it was like a connect the dot test. But they were told to go as quickly as they could and they were timed to see how fast that they could complete this. Then in trail making test part B, it is very similar, but it includes going back and forth from number to letter to number to letter. So they start at 1 and then go to A, then A to 2, 2 to B, and so forth until they reach the number 13. Again, they were asked to do this test as quickly as possible because they were being timed. So now to talk about the results, I want to first talk about the analysis we used to analyze the data that we collected. So a repeated measures ANOVA was used to determine if there were meaningful differences between any of the 3 time points of testing for the 6 cognitive domains and for the self-report measures as well. So we ran the ANOVA, and if we found a significant difference in the overall model, which was indicated by a p-value of less than 0.05, then we conducted an effect size statistic as well. The effect size statistic we used was Cohen's d, and this is a measure of clinical significance. So it's a different way to look at the data. Rather than just looking at the p-value, if it was statistically significant, we also looked at this Cohen's d, which then was saying, is this something that's clinically significant or meaningful? A meaningful effective change. So the table here shows a general guideline of the strengths of the effect sizes, ranging from small to extremely large effective change. So now to get into talking about the results of the cognitive domains, I'll first kind of explain what the graphs are showing here. So the graph shows the mean scores of participants at pre, post, and follow-up testing here. Pre is in green, post is in red, and follow-up is in orange. So it's important to note that on the R bands, a score of 100 is considered dead average at the 50th percentile, and then a score of 85 is 1 standard deviation below average, and a score of 115 is 1 standard deviation above average. Just to give you guys a sense, 100 is dead average here. So now, looking at the attention and concentration domain here, we can see that there's a slight decline at post-test and then an increase 1 point higher than baseline at follow-up. Although we can observe these small differences, results from the repeated measures ANOVA revealed no main effect, which means that there were not any meaningful or significant differences between any of the time points here, pre, post, or follow-up. Now, looking at the visual spatial domain, a main effect was found. So there was a statistically significant increase between pre and post test here, indicating that there was a meaningful difference that we can infer was not due to chance. So we're inferring that this is due to the cognitive training class, possibly. So the effect size from pre to post was a Cohen's d of 0.63, which indicates a medium or moderate effective change. Another test that we utilized to measure visual spatial skills was visual puzzles. So there was a slight increase from pre to post test, and this increase was stabilized at follow-up test. However, these differences were small and not very meaningful, as there was not a main effect found in the overall model of the ANOVA. For the immediate memory domain, a main effect was found. The significant difference lies between post-test and follow-up test at a p-value of 0.03 and an effect size of 0.67, indicating a moderate effective change. Then looking at delayed memory, a main effect was found here as well. So this means that overall participants were able to retain information from the immediate memory test and recall it after a 20-minute delay. And participants improved on this task over time from post-test to follow-up and overall from pre-test to follow-up. So there was a moderate effect from post to follow-up, and there was a very large effect from pre-test to follow-up here. So these findings on immediate and delayed memory are particularly relevant to older adults experiencing age-related cognitive decline because many do report subjective memory complaints and are concerned about improving their memory to improve their overall cognitive health. So now looking at the language domain, no main effect was found, so overall there were no meaningful differences between any of the time points on this domain. Then looking at the processing speed domain and the problem-solving domain, we used Trails A to assess processing speed and Trails B to assess problem-solving. So as you may recall, lower scores indicate higher functioning, as participants were asked to go as quickly as they could to complete both trail-making tests, Part A and Part B. So for Trails A, scores were very similar across time and no main effect was found. Then for Trails B, scores declined somewhat over time, because you can see those numbers got a little higher over time. But these declines were not meaningful as no main effect was found. Then looking at the overall composite score of all measures of the R bands, we have what's called the total scaled score of the R bands, which is a composite score of each domain that we just talked about here. So there was a main effect found when we compared scores on pre-test, post-test, and follow-up test here. So looking at the graph, you can see that there were increases from pre to post and from post to follow-up. The most meaningful improvement was found from pre to follow-up test with a p-value of 0.01 and an effect size of 0.76, which indicates a moderate effective change over time. So then lastly, analyses were conducted on the self-report measures. The first measure shown on the graph is the PHQ-9, which measured depressive symptoms over time. So all mean scores were in the healthy or normal range on this measure, and there were no meaningful differences over time on this measure. They're very low, so a score above 5 is what we consider clinically significant depressive symptoms, and everybody scored fairly low on this. As you can see, the mean was 1.53 at baseline, and that just slightly declined, but nothing meaningful changed here because scores were very low. The cognitive failures questionnaire then assessed how often minor cognitive errors occurred in individuals' everyday life. So lower scores indicated higher functioning here. We saw slight improvements over time on this measure, however, no main effect was found. So no meaningful differences over time here. And then the frequency of forgetting questionnaire assessed participants' judgment of their own memory capabilities, and higher scores indicated higher functioning here. So there were no differences on this self-report measure over time, as no main effect was found. So now that I've made it through all of the results here, I want to discuss the positive and negative findings from this study and why these results may be. So there was not an improvement on these cognitive on the cognitive domains of attention, language, processing speed, and problem solving. So this could be because these domains are very broad constructs, meaning that they involve many different skills. So for these domains, the skills that were taught in the class may not have been accurately assessed on the measures used in this study, since they were very broad domains that involve many different skills. It is also possible that these domains were not targeted as much as needed to see improvement over time. This is a comprehensive cognitive training program that aims to target 6 domains. However, more time is devoted to some domains than slightly more than others. So there was an improvement on the cognitive domains of visual spatial skills, immediate memory, delayed memory, and that composite score on the RBANS, which is otherwise known as global cognitive functioning. So this could be due to the content of the cognitive training program. For the domains of visual spatial skills, classes included a variety of visual spatial tasks that required mental rotation or reversal of visual stimuli, which were skills that were assessed on the measures of visual spatial skills. For the domains of immediate and delayed memory, approximately 25% of each class focused on tasks involving immediate and delayed verbal memory skills, similar to those assessed on the RBANS. And then for the comprehensive measure of all 6 cognitive domains, otherwise known as global cognitive functioning, there was an improvement as well. There is not an improvement on the self-report measures. So this could be because individuals rated themselves in the average to above average range on these measures, leaving little to no room for improvement. So on the PHQ-9, which assessed depressive symptoms, the mean score was a baseline of 1.5. A score above 5 is clinically relevant, so participants scored in the healthy range where little to no improvement could occur. Then on the frequency of forgetting scale, participants rated their memory capability as average across time. And then on the cognitive failures questionnaire, participants reported that the frequency of their cognitive errors were average across time as well. So now to kind of wrap things up and conclude about what we found from this study, the findings of the current study provide preliminary support for the use of a cognitive training program for healthy older adults. A moderate improvement on global cognitive functioning was observed, and small to large improvements were observed on visual spatial skills and immediate and delayed memory. These results are encouraging, particularly considering that the participants already had average scores at baseline, otherwise like average levels of cognitive functioning, we could say, before the program began. Additionally, it is important to note that the cognitive training program utilized in this study targets 6 cognitive domains. It was delivered in 1-hour sessions, which is not overly cumbersome compared to other cognitive training programs. It was well received by participants, and the facilitators reported liking the program as well. In the future, additional research with larger samples and appropriate controls is needed to make more definitive conclusions about the efficacy of this cognitive training program. However, that is what we have to say about the study. Again, I'd like to thank the following people that were mentioned at the beginning by Jeff, and again, just point out if you have any questions, feel free to email Dr. Jeff Buchanan and or call him. So thank you all for listening.